So we have.
Hello, everyone. It's a great pleasure to be here, although remotely. And I want to thank my friend Ahmed for this very great invitation and for the amazing conference. So today I'm going to talk about inspection from inspection to action in endoscopic prediction of submucosal invasion to guide EMR versus ESD. And those are my conflict of interest. What is important to remember is that colorectal cancer is the fourth cancer in the world for incidence and one of the highest cancer for mortality. So although there are some screening in place, we're not doing enough to manage this cancer. And early detection and resection of precancerous lesion is very important and mandatory for a better prognosis. So here are the ESGE guidelines. And as you can see, that is the update of 2024. So when to choose EMR or ESD? For the ESGE guidelines, we should choose EMR or ESD only for lesion in the rectum bigger than 2 centimeters and for lesion with suspicious of deep mucosal invasion. In addition to that, colorectal lesion with NICE2, JNET2A, our low-grade dysplasia should be removed by ESG guidelines with polypectomy or EMR. JNET2B, if are in the colon and there is no suspicion of invasion with piecemeal EMR, if they're in the rectum or there is suspicion of invasion, they should be removed unblocked with EMR or ESD or surgery. NICE3 or JNET3, so deep submucosal invasion, should be removed by surgery after proper staging and plus or minus chemoradiotherapy. Now, how do we recognize that the lesion is more suspicious for invasion? Well, we still relied on the Paris classification and on the morphology. I'm not going through the Paris classification because I assume you are familiar with that. So the lesion with a higher risk of deep invasion are the 2A, 2C component, and the one with mucosal depression, which is 2C, although also sessile lesion has an increased risk of deep invasion, and the 3, which are excavated, are many a times, unfortunately, already involving the muscle layer. In addition to that, we have also lateral spreading tumor, which are sessile and flat adenomatous lesion, larger than 10 millimeters, and are part of the 5% of all polyps found during the colonoscopy. And we know that they have a different range of risk of invasion depending on the morphology. So LSTG homogeneous type reported from a Bark study from the Sydney group show that the risk of invasion is 0.5%. The non-granular flat elevated is around 5%. The granular nodular mix can go up to 10%, and then non-granular pleurodepressed can go up to 31%. And in the rectosigmoid location, the greater is the lesion in terms of size, and the more, and if it's located in the rectosigmoid, then the higher is the risk of SMIC. In terms of pit pattern, we use different classification. The CUDA one is the most used, but we also use many a times JNET classification, which is nowadays more, simplified. So type 2 is usually low-grade dysplasia, and type 2B is high-grade dysplasia or superficial submucosal invasive cancer. And in this case, endoscopic resection is still indicated, while type 3 it's for surgery because it's probably deep submucosal invasive cancer, and type 1 is hyperplastic polyp or sessile serrated lesion. Those are the other classification, but essentially it's this very similar story. Now, let's discuss briefly about EMR ESD. So EMR, as you know, you inject underneath the lesion in the submucosal space, you elevate the lesion, place the nerve around, and remove the polyp. ESD, and if you have a large lesion with a piecemeal EMR, you have to remove the polyp piece by piece. ESD is instead, you inject underneath the lesion, and then with a knife, you dissect underneath the lesion and you remove the lesion en bloc. Now, the risks are EMR has around 1 to 2% risk of perforation, and the risk of bleeding during the procedure and after the procedure. ESD has about 4 to 5% risk of perforation, and there is a risk of bleeding during the procedure, usually is using, and it can be managed endoscopically. In terms of surgery, ESD has been proven to be very safe, and the risk of surgery following a perforation is extremely small, is less than 1%, far less than 1%, and it's when we're not able to close the defect endoscopically, which is very rare, or is when we have a post-ESD perforation, which is 0.5% risk. So all in all, ESD nowadays, even in the Western countries, is very safe. And all in all, nowadays, there are more and more endoscopists performing ESD, especially younger endoscopists, because the ESD has spread a lot across Europe. We don't have to go to Japan anymore to learn ESD. We can learn it here in Europe. We have excellent centers. And what are the main benefits? If you do a piecemeal MR and is intuitive, you don't provide to the pathologist the full specimen. So you ended up giving him small part of specimen, and the pathologist won't be able to give a full assessment. In addition, sorry, on the opposite with ESD, you can give the full specimen, and the assessment is thorough, and you can tell if the histopathologist can describe about the margins, can describe about the lesions, the cells, the budding, when there is the budding, the lymphovascular invasion, etc., in details. The other thing is, when you do piecemeal MR, you might leave some cells in place, and you'll never know, because you don't have the whole specimen to give to the pathologist. In terms of recurrence, ESD, if it's completely remove and block with R1, R0, sorry, with no R1, but only R0 lateral and deep, then the risk of recurrence is almost zero. And on top of that, the follow-up endoscopy should be in 1 year time. But nowadays, the guidelines are, and the evidence is kind of pushing the boundaries. And there are some groups that are pushing for a later follow-up, which is very important. For EMR, the follow-up is after piecemeal MR, 3-6 months, and then 1 year. Now, yes, there are some groups that advocate the fact that if you use ablation, you can have around 2%, 3% recurrence rate. First of all, this is only in expert center, and the variety of recurrence, there is a wide range. It goes from this 2 to 3% to 20% in non-expert centers. Second of all, if you have a recurrence, then you have to treat the patient again. And if this recurrence is not treatable again with EMR, you have to go to the ESD. But the thing is, with EMR, piecemeal EMR, you have to do a colonoscopy in 6 months' time, and then in 1 year time, and then in 3 years' time. And if you have a recurrence, you go back to square one. So with ESD, if you are at zero resection, you go for 1 year, or maybe in the future for 2-3 years. So there are a lot of benefits around that. And this is important. Saying that, the SMIC for this procedure, so the depth of invasion in Western countries was about 4% to 6%. And in Japan, it's been much higher, between 11 to 21% risk of deep submucosal invasion. So where is the difference? And I'll tell you what, we recently done a multi-center study with more than 3,000 ESD in Europe, the study was led by my team at the Royal Free Hospital. And we found that the overall rate of risk of submucosal invasion is about 18%. So it's much higher than what previously suggested by guideline, by Western evidence. And why? The big difference is because this study was only based on ESD rather than piecemeal EMR. And I'll tell you what, in addition to that, there is also, of course, LSD non-granular pseudodepressed have a risk of invasion between 23 to 40. The LSD non-granular flat elevated have a risk of invasion that goes from 6% to 27%. The sessile risk of from 12 to 36, and the LSD granular mixed nodular have a risk that goes from 13% to 90%. But even the granular homogeneous type, which were reported as very low risk, has a risk that goes from 6% to 11% of deep submucosal invasion. So there is new evidence, and I think hopefully we're going to publish soon this data, but hopefully the guidelines in the Western countries will adapt. So yes, morphology is important. Yes, describing the lesion and looking at the lesion, interrogating the lesion pattern is important, but it's not 100% reliable. So what about this lesion? This lesion is a lesion in the rectum, is 2 centimeter. It's 1S with probably 2B, 2A, 2B. And when we resect this lesion, it's a 77 years old man with multiple comorbidities, and it was carefully assessed with the MBI, near focus, and we decided to go for site PCM ESD, done in 50 minutes, non-complication. We found that this was a sessile tubulovillus adenomatous polyp with high-grade dysplasia with associated submucosal well-differentiated adenocarcinoma. There was an invasion of the tumor of 6 millimeter, Kikuchi level SM2, SM3, and BD1 budding, but no lymphovascular invasion. Because of the patient comorbidity, we went for conservative management. There was an R1 in the deep margin of 0.4 millimeter. Conservative management because of patient comorbidity, 1 year follow-up, fine. No recurrence, healthy scar. What about this lesion? This is a lateral spreading tumor, which is non-granular, pseudodepressed, I would say. And which resection would you choose? We went for an ESD. Here, the trimming. Here, we are approaching the center of a lesion. As you can see, there is quite fibrotic in the center. We were a bit worried about a deep invasion. We continue the trimming and the cutting. And as we go forward, we pass that area of deep fibrosis. So we make a circumferential incision, and then we open the pocket. What was the result? This was tubulovillus with low-grade dysplasia, R0 resection. And in theory, because of the initial picture, this should have been, you would have thought that this was going to be a much risky lesion regarding deep submucosal invasion. I'll give you another example. What about this lesion? This is 1S2A, and it's a 50 years old man, 6 centimeter lesion in the distal ascending colon, carefully assessed, 2A, JNET 2A, 2B, and removed with a site PCM ESD, no complication. This is a lateral spreading tumor, granular mixed type. And guess what? We found that it was high-grade dysplasia with associated invasive, well-differentiated adenocarcinoma. And the depth of invasive tumor from the muscularis mucosa was 3 millimeter. So it was a lateral R0, but R1 in the deep margin, but there was a deep diathermist excision margin. So it was R1 or Rx. Anyway, the patient was sent for surgery, and guess what? There was normally or dysplasia present in the surgical specimen. So this was curative. ESD was curative. Now, in the sake of time, I'll jump to the conclusion. But this is important because my whole talk is about characterization, is about lesion. And the fact is that the risk of SMIC of deep submucosal invasion is higher than currently reported in the West. And what we found from our multicenter studies that comparable to Japanese data. So the piecemeal EMR risk of non-curative resection and loss of histological information, it seems to be much higher than what we think. So a thorough assessment, it's important, but cannot be fully reliable. So I would recommend to discuss this lesion in the MDT and tailor a therapy on the patient, but also I think that we are witnessing a paradigm shift where we should use ESD for unblocked resection rather than EMR more and more. And this, I hope, would be the future. I thank you all. I thank my team, as usual, my good friend and colleague, Ed, whom we direct our therapeutic activity at the Royal Free Hospital. And also we are co-director at the International IAM, which you are invited. It's going to be between the 15th to 17th of April. And again, thanks again to all our team. Thank you, and bye for now.
Thank you very much, Alberto.